Welcome to the conference session titled Low-Risk MDS. Thank you so much for joining us. My name is Nyari, Patient and Professional Programs Coordinator at AMDS. As we get started, AMDSIF would like to recognize the generosity of our corporate sponsors. At the diamond level, we have Alexion and Novartis. At the gold level, we have Apellis and Genentech, and the generous support of our patients, families, caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. When asking your questions, please wait for the microphone so everyone, including those watching online, can hear your question. If you are participating online, please type in your question using the Q&A button on the bottom of your screen. We will do our best to get to everyone's question. When you're asking your questions, please do not share any private health information, as our speaker cannot answer specific questions related to your healthcare. Today's specialist is Dr. Andrew Matthews. Dr. Matthews is an oncologist with the clinical and research focus on hematological malignancies. He's an assistant professor at the Hospital of the University of Pennsylvania and the medical director for hospital operations, HUP Oncology. With that said, please welcome Dr. Matthews.
Hi, good morning, everyone. And first, I just want to say thank you to the Aplastic Anemia and MDS International Foundation for inviting me to speak, and also to Dasha and Tim in particular for extending that invite. So just in terms of what we're looking to cover today. So I'm going to talk a little bit about what is MDS, first of all, and then past that as well to talk about what's our approach for diagnosing MDS, risk stratifying MDS, how do we put MDS into risk categories, the current treatments that we think about today, and then a very little bit about what's sort of coming down the pike, okay? The other thing too is that oftentimes when we're asked to give talks or other things like this on a topic, it's basically, an hour-long talk that we would give to other medical specialists. And the goal of today, as you heard in the other room, is more to give everyone a chance to ask questions, and in particular to make sure that you're leaving today feeling more educated about what's going on than you did when you first got here. So with that said, I have no financial disclosures. We'll have some off-label discussion today about how we use certain drugs, and I will acknowledge that as we get to it. So what is myelodysplastic syndrome? Myelodysplastic syndrome is a disorder of hematopoietic or progenitor stem cells in the bone marrow. Normal function of the bone marrow is to make all of our blood cells, in particular white blood cells, red blood cells, and platelets. And in myelodysplastic syndrome, instead, what happens is there's usually a mutational change in the progenitor cells and a reproduction and growth of those progenitor cells over time, crowding out the bone marrow and taking over the normal function of the bone marrow. And what that means is that there's usually also abnormal and less cells out in the peripheral blood. The other thing I'll just do as an aside is to say that MDS is part of an unfortunately proud tradition of poorly naming things throughout medicine. A lot of things in medicine were first named somewhere back in the 1920s or about 100 years ago by people who actually didn't understand Greek or Latin very well. And that's how they ended up in medicine as opposed to Greek or Latin scholars. So that said, because I've been through enough Jesuit education in my life, I will also tell you that it actually, myelodysplastic syndrome, coming from myelos in Greek, referring to marrow or the spine. So that gives you some idea that we've learned a lot over time. And dysplasia being abnormal formation or abnormal appearing cells, okay? That's really all that myelodysplastic syndrome means. The other thing, and the reason why I mention this, is because over time, there maybe 20, especially say 20 years ago, there was a reluctance to refer to this as a cancer. And we have really gotten to the point of saying that this is a clonal disease and referring to myelodysplastic syndrome as a cancer over time. As a matter of fact, the World Health Organization in their newest diagnostic guidelines to us actually even recommended talking about this as myelodysplastic neoplasms. They still like to abbreviate an MDS because it's hard to change all your materials and things like that. But just to emphasize that point, okay? The other thing that I just want to say is that this is a rare disease, typically of older adults. The incidence in the United States is 4 in 100,000. So to give some perspective on that, that's about 30 times less than the incidence of breast cancer in the United States. So what that means is that it's important for you to become educated about this, because oftentimes you're going to have to educate other people about your condition. It's also important for you to be with a team that is used to treating this disease. And even if that's not who you see every month or every week or something like that, but to have that experience of going also to a practice that is used to treating patients with myelodysplastic syndrome. I won't talk that much for every slide, I promise. I just want to sort of level set as well too. So what are the symptoms of myelodysplastic syndrome? The major thing is that, again, we're seeing fewer and poorer quality peripheral blood cells. And the bone marrow is having a disorder in the hematopoietic stem cells and progenitor stem cells, and that leads to lower red blood cells, white blood cells, and platelets. And red blood cells carry oxygen and sort of give us strength. And anemia is the most common cytopenia in MDS. Over 80% of patients will have anemia as part of their disease. 50% of patients, when they're diagnosed, will require red blood cell transfusions to maintain a hemoglobin at a level that doesn't cause symptoms. What are the symptoms of having anemia? Fatigue, passing out, high heart rates, shortness of breath, chest pain, paleness, even decreased appetite, all potentially are going through in part of having anemia. The other blood cells are a little bit less commonly affected, but it's an important consideration. And neutropenia, or low white blood cell count, can also lead to frequent infections. About 50% of patients have a decrease in their neutrophils. And then thrombocytopenia, or a low platelet count, can lead to issues with bleeding or bruising. And about 50% of patients have some decrease in their platelet count below the normal level of 150, but it's rarely an isolated finding. It's not usually that people are presenting to us with low-risk MDS and just thrombocytopenia. That is rare in somewhere around 5 to 10% of patients. So in general, who tends to be diagnosed with MDS? What are the risk factors for being diagnosed with MDS? The major thing is that MDS is a disease of aging. All of us accrue mutations in our bone marrow over time. And that rate, if we actually were just to look at healthy people's bone marrow out in the United States or in other settings, what we would find is that around 10–20% of people by the age of 60 have some sort of new mutation in their bone marrow that wasn't there. And some of the mutations that people develop change over time and actually lead to something like myelodysplastic syndrome. Oh, sure. All right, perfect. Still in the world of being digital is great, even now, a few years into the pandemic. So MDS is rare before age 60. The median age of diagnosis in the United States is 70. And so when we think about this, it also becomes that we think more about kind of the third bullet point down here, where we think about, is there any role of looking to see if there's an inherited or a family syndrome leading to be more likely to have MDS? The rate of having a familial syndrome or a genetic predisposition to developing MDS can be somewhere around the 10 to 20% range in folks that are 40 or 50. The other major risk factor that we know for myelodysplastic syndrome is actually having therapy for another type of cancer. Therapy-related MDS or MDS that develops after some sort of other type of chemotherapy is 10 to 15% of all MDS cases. So what we really think is happening is when people receive treatments for other types of cancer, it allows the pre-existing bone marrow that has changed those cells to reproduce and grow better in the setting of something like chemotherapy knocking down the rest of the bone marrow. okay? And then in terms of environmental risk factors, there aren't too many common risk factors that we know of that really lead to myelodysplastic syndrome. There's some things like occupational exposures like benzene or radiation, and tobacco exposure is a little bit linked, as well as a BMI higher than 25 in some series, increasing the risk of MDS. But none of these are sort of the smoking gun. And most often than not, this is just a change that has happened, a mutation that has happened randomly in the bone marrow and then led to further problems. A quick word on what is not myelodysplastic syndrome. And this is a slide just to outline that there's a whole bunch of terms for the types of processes that are happening in the bone marrow before we think about actually calling something myelodysplastic syndrome. And so this table of just sort of laying out that there's a whole bunch of things that we really think that sort of go over into what makes something in myelodysplastic syndrome, which certainly has low blood counts. It has abnormal looking cells. It's clonal, meaning that it's the same cell reproducing. There are mutations that we know are associated with myelodysplastic syndrome, and there's a risk of the myelodysplastic syndrome changing and transforming over time. There also are things in the bone marrow that don't meet all of those criteria, and we've developed names for those things over the last decade or so. The point that I just want to emphasize on this is there's a spectrum of changes that can happen in the bone marrow that we can identify even before it becomes myelodysplastic syndrome. And that this really runs a full spectrum all the way up to myelodysplastic syndrome. And on this slide, just to show you too, that myelodysplastic syndrome can also be in itself a full spectrum of risk, of low risk to high risk to burgeoning over into acute myeloid leukemia. So what we really think over time is that there are some changes within the bone marrow that we could pick up if we were going around and sampling everyone's bone marrow and doing next generation sequencing genetic testing on everyone. We could pick up those mutations. People wouldn't even necessarily have anything else abnormal that we could tell in their bone marrow or in the peripheral blood, but we could see those changes. We call that CHIP, or clonal hematopoiesis of indeterminate potential. This could develop over time to then affecting, say, the red blood cells or one of the other types of cells. And then we would be able to pick up this mutation and say that this is a clonal cytopenia of undetermined significance, or CCUS. And then something else might change in the bone marrow, and then we're talking about something becoming a myelodysplastic syndrome. Okay. And we've learned more and more over the years, and I'll talk about this a little bit more when we talk about how do we assign risk categories to myelodysplastic syndrome. The types of mutations that we see are also different along the spectrum of disease. And this is something we're learning more and more about every year, and probably in the next 5 or 6 years, if we continue at the current rate of having new ways of risk stratifying people, we'll be able to have a completely different conversation around this too. So how is MDS diagnosed today? So typically what we're talking about is some sort of initial exam, doing blood tests that identify some level of one of those 3 major types of blood cells that we see in the blood being abnormal, a bone marrow biopsy, and then cytogenetic and mutation testing. So the key components on that are a bone marrow biopsy really is a critical part of diagnosing MDS for everyone. And then the next part about that too is actually doing testing of the genetics of the bone marrow cells, cytogenetics, and mutational testing. The differential diagnosis, what else could look like abnormal blood tests but isn't MDS until we do a bone marrow biopsy to see, can actually be pretty long. And it's actually also important for us to consider any of these other factors that may be contributing to someone's low blood counts when they come to see us. So someone, for example, could have a nutritional deficiency in copper, and that could look all the world like a myelodysplastic syndrome. And what they really need is they need copper supplementation. Dr. Prats, who joined us in the back of the room, he and I saw a patient together who I think had 3 or 4 bone marrow biopsies and a few other issues along the way before she came to see us, and then got copper supplementation and recovered all of her counts. She also at the time had, I think, about 50 pounds of unintentional weight loss as well, or some level of intentional and unintentional weight loss. So my point on that is more along the lines of it's really important when you're first being diagnosed and evaluated that it's a thorough workup and evaluation, and that also there's some thought process as well to, is there anything else contributing to the abnormal blood counts? Genetic testing, I'm going to talk about over the next 2 slides. There's 2 major components to looking at the genetics of MDS today. One is karyotyping. And karyotyping involves actually actively dividing cells, extracting the DNA out of those cells, staining them in the lab, and then looking at them underneath a microscope to see how the chromosomes look in cells. I only go through that detail to give you some idea that it's something we've been doing for a long time, and that that's not the same as, say, the next generation sequencing or looking at particular mutations that we talk about all the time. This is looking at changes in whole big structures or pieces of DNA. And approximately half of all people with de novo MDS or newly diagnosed MDS without any history of exposure to chemotherapy or anything else like that have an unbalanced change resulting in the loss or gain of a chromosome or a whole piece of genetic material. And the loss or gain of those chromosomes changes the expression of genes in those cells. And so that's how we've been looking at this for a very, very long time. And as far as that goes, that's helped us over the years to classify people into having normal cytogenetics or abnormal cytogenetics, and then also being able to risk stratify from there into low risk or higher risk genetic changes. A key thing, though, over time as well, too, has been the ability to look at individual mutations and individual changes. And most series would tell us that around 90 to 95% of patients with myelodysplastic syndrome will have an identifiable genetic change when we do next generation sequencing for them. And the types of genes that can be changed and be mutated that we see in MDS, there are a lot of them. And I've listed just a few of them up here, and this was a nice review by Dan Steensma from a few years ago. But these types of genetic mutations are somewhere, some of them we see in 10 to 15% of patients, some we see in 25% of patients or so. And they all potentially have their own particular effects. And some of those are really important for how we select treatments today for people. And some of them are going to be really important for how we select treatments in the future for people as well, too. What's different about this is that this is different diagnostic testing than we used to do. This requires a full, what we call NGS or genetic testing of the blood. And it used to be that that wasn't necessarily the standard approach for all of our patients. A lot of patients with MDS may only had a karyotyping that was done, and more we are relying on full genetic testing, at least in the United States, to help us really have a discussion about risk and treatment approaches for patients. And I'll get to that a little bit more. So the risk with MDS varies widely by blood counts and genetic changes. To maybe put it another way too, of really running a spectrum from very low risk disease to very high risk disease. There's actually a gentleman at the VA who used to call it minimal dysplasia syndrome, which, not to make too light of the situation for him, but he called it that because he would show up and get blood testing done every couple of months, and that was his MDS. And then there are other patients who, when they're diagnosed, they have quite a lot of changes in high-risk genetic features, and we think about and manage their situation much closer to how we manage someone with acute myeloid leukemia or full-blown blood cancer. So how we've been thinking about this and approaching it is there's an agreed upon international prognostic scoring system, and it was revised, and I'll show you the timeline of what that looks like, but was revised from the original IPSS that was developed in 1997 And it's had been the most commonly used risk score. And it looked at blood counts, and it looked at the percent of immature cells in the bone marrow, and it looked at cytogenetic changes. And then most recently, we've also then been thinking about and adding in, how do we change the risk categorization of patients based off of those individual genes that might be changed as well too. So I'll talk about that. But using the revised International Prognostic Scoring System, about 77% of MDS patients are considered lower risk, either very low risk, low, or intermediate risk. And about 23% of patients, when they're diagnosed, are considered higher risk. In clinical practice, we actually use a cutoff in the score of about 3.5. And I'll show you the score on a separate slide so you have some idea in the background. The other thing to mention here too is that this is a score that's used when we think about it and when we talk about it, initially used at diagnosis, but this disease changes for people and can evolve over time. And low-risk disease can become higher risk disease. And we'll talk about that too, okay? Just to give some sense of where we've come in all of this. I don't mean us to go all the way back to the 70s, but the IPSS, the initial International Prognostic Scoring System, was developed in 1997. We continued to sort of learn more about how we think about and classify MDS. It was revised in 2012. And then, another 10 years after that, we really came out with the major way of how we incorporate mutations into this as well, too. So to give you some sense, myelodysplastic syndrome, really that term became more popular in the 1920s or so. And then we developed the IPSS in 1997, about 50 years later. And then 15 years after that, we developed a whole new scoring system. And then 10 years after that, we developed a whole new scoring system. So my point on that is we really are learning more all the time. And how we think about this is probably also going to evolve all the time. So what does the score actually look like today for the revised IPSS? So it varies by cytogenetic changes, the karyotype changes when we look at the chromosomes underneath a microscope and look at it further from there. And that can range all the way from not contributing anything in terms of risk to all the way on the other spectrum of having multiple changes, like more than 3 changes, leading to us considering a complex cytogenetic risk. And then we also look at the percentage of marrow blasts or very immature cells in the bone marrow. We look at the hemoglobin level, the neutrophil count, and the platelet count. And all of that is used to then classify patients into a risk category. And by risk, there's differences in how long, on average, people tend to live, which is shown in the table there. And then also there's a risk of the disease progressing to something like acute myeloid leukemia. And that this sort of helps, I think, kind of emphasize the real full range that you might see as well, too, from one end of the spectrum all the way to the other. This, again, doesn't actually take into account all of those mutational changes that we might see. It does to some extent in that as we see changes in chromosomes, we would expect to see changes in how genes are expressed. But when we actually look at genes that are changed within myelodysplastic syndrome, what we basically found is that a group came out with the molecular IPSS. And with that, we're actually, in general, looking at a whole range of genes, but in particular, about 15 genes that are thought to be really have a large impact. And then a whole additional set of other genes, too, that also are thought to impact risk along the way. And we're actually, the MIPSS is able to divide patients into the risk categories shown here, which is very low, low risk, moderate low, moderate high, high, and very high risk MDS. And the spread of what we see when we look at overall survival by risk stratifying this way too, you can see that there's big differences across all of these categories of how well people do over time. And the reason for that is the presence of these genes really can change how the disease is behaving or the risk of disease progressing for patients. When we incorporate genetic testing into our traditional testing, when we look at the molecular changes, we would actually change about how 10 or 20% of people are categorized in their risk by our traditional methods of looking at things, okay? So what that means is that around in the studies that have been done, and a lot of people have published some really great work on this over the last 2 years or so, is that we might upstage or say that a low-risk patient is actually a moderate-risk patient, or a moderate-risk patient is actually a high-risk patient, somewhere around 10 to 20% of the time for low risk, and for moderate risk, somewhere around 20 to 30% of the time. So again, I worry that talking way too much about that particular point, but just to say that this is sort of the role that the actual next generation sequencing and mutational testing plays in helping us have the right conversation about what to expect and how to approach someone's treatment. This is just a table that breaks out some of the longer term outcomes by classifying people by the IPSS-M score. And I don't think we'll need to talk about it here other than to say, and just to point out that, again, there's just a really wide spectrum, and in very high risk disease, we actually are thinking about this pretty much as interchangeable with how we think about our approach for patients with well-controlled AML, because the risk of transitioning to AML within a year for patients with very high-risk disease is close to 30%. And I think I'll probably just leave it there for that particular slide. So how do we manage low-risk MDS today? So after we arrive at a diagnosis of myelodysplastic syndrome, after we've considered, is there anything else that could be going on? After we've done peripheral blood testing, after we've done a bone marrow, and then we can turn around and use the risk categorization scores, we can classify people as low-risk MDS or high-risk MDS. And I won't be talking about high-risk MDS. That's our next talk. But within low-risk MDS, then oftentimes the approach that we take is say to ourselves, okay, is someone symptomatic from their disease? Is someone symptomatic from having low blood cell counts? And if they're not, then our approach with that is to really say that we should do surveillance and we should follow up blood tests. If there's changes, we should think about whether or not there's a role for repeating genetic testing or repeating a bone marrow biopsy. And we are able to do surveillance. For patients that have multiple changes across white blood cells, red blood cells, and platelets, we're actually really thinking about treatment with something called a hypomethylating agent, or HMA. And that's more something that we talk about in the setting of high-risk MDS. And for those patients, a lot of times too, we're also thinking to ourselves, is this someone that would potentially benefit from something called a bone marrow transplant as well too? But the bread and butter of low-risk MDS tends to be more in the world of someone having an isolated cytopenia, isolated problem with, say, just one of their cell lines, or I might rephrase that as a predominant problem with just one of their cell lines. And in particular, like we said earlier, that's usually red blood cells. And so when we're thinking about how we approach our patients with anemia as their major problem in low-risk MDS, we ask ourselves, hey, what did that karyotype look like? Is there a change in something that we would call del5q, which I'm going to talk about on the next slide? And if so, we have a drug that works very well for that setting initially, lenalidomide, and I'll talk about that. But if someone doesn't have that particular genetic change, then we ask ourselves, okay, what's the natural level in their body of erythropoietin, or the hormone that causes the bone marrow to make red blood cells? And if that's low, then oftentimes traditionally what we've thought about then is giving an erythropoiesis stimulating agent. And if it turns out that the EPO level is high or erythropoiesis stimulating agent doesn't work particularly well, then we have lots of options, including luspatercept, and then imetelstat is a newly approved option as well too, and I'll talk about those. There's been over the last 18 months or so as well too, there's been an evolving role to use luspatercept even in patients who have not yet been treated with an erythropoiesis stimulating agent. And I'll talk a little bit about that. So in general then too, it is, like I said, just to round out in talking about the isolated cytopenias, it is rare that we're seeing patients where thrombocytopenia is their main problem. It's actually kind of a difficult scenario for a lot of us to deal with. I'll talk about some of the data and options there. It's not particularly common. And then neutropenia or low white blood cell count is also something that we approach a little bit differently as well too. So I mentioned in this how we approach things, del5q. So what am I talking about when I say del5q? On the left is a picture of what a karyotype looks like, or when we take all the chromosomes out of dividing cells, throw stain on them, and look at them underneath the microscope. And it turns out that there's a number of people that have a genetic change called del5q, where they are missing the Q end of chromosome 5. And this genetic change is actually what leads to their MDS. It leads to a clonal proliferation of cells. It leads to an anemia, a low red blood cell count. And it often also leads to a slightly high platelet count as well too for these patients. And it also means that there's a drug called lenalidomide that actually works for this group of patients because of the particular changes in their genetics. And what we see is somewhere around 2/3 of patients have a response to lenalidomide with a duration of response, ongoing improvement for as long as 2 years. And we're actually learning more and more now too. There's a really interesting study out of the Spanish group within the last year, and actually was just published a few months ago too. The abstract was at ASH, but they just published it not too long ago, where there is some advantage to treating with low-dose lenalidomide early in someone's disease, even before they developed the need to get regular red blood cell transfusions. And they actually found sort of a disease-modifying effect, or what they argue is a disease-modifying effect, in starting treatment even a little bit early in folks with this particular change. But lenalidomide is mainly restricted to being used in patients that have this particular genetic change. So that's why I'm not necessarily going to be talking about it a whole lot, or across the whole group of our patients. There is some evidence of lenalidomide's efficacy in MDS without del5q, but the response rate is way lower. It's about less than half that we would see in patients that have this genetic change. The mainstay of treatment that we have for low-risk MDS with anemia as the primary cytopenia is the erythropoiesis stimulating agents. And there's 2 major ESAs that are commonly used in the US, EPO and darbepoetin. And the way that EPO works and the way that erythropoiesis stimulating agents work is that the kidney makes the hormone EPO. It goes to the bone marrow. It binds to progenitor cells in the bone marrow. And those cells make and produce early forms of red blood cells called reticulocytes. And then those develop over time into red blood cells. And so the thought process was, and the way that this developed in clinical practice, is to say, okay, well, if the body naturally makes erythropoietin, why can't we use something in the lab similar, develop it? And that's what erythropoiesis stimulating agents are. They're just sort of analogs to what the body naturally makes. How do we use it? We usually use erythropoiesis-stimulating agents to try to maintain patients with a hemoglobin of somewhere around 9 or 10 without needing transfusions. Its main utility is in low-risk MDS, and response rates are typically sort of quoted in the 40–50% range, but it really varies a lot by what's the baseline serum EPO level that a patient has. And in the right patient population with a low EPO level in their blood, it turns out that giving erythropoiesis-stimulating agents is very helpful to around like almost 70% of our patients. There are some groups, and it's even a little more common in Europe, that think about adding in GCSF or granulocyte colony stimulating factor, another agent, if the response to erythropoiesis-stimulating agents isn't as good as we would hope after about 12 weeks or so. It's a little less commonly done, quite frankly, in the United States. The other thing too is that, like I mentioned, we can consider whether or not adding lenalidomide might be a useful thing to do for patients that aren't having a great response to erythropoiesis-stimulating agents. We've been using those ESAs for a fairly long time. And then recently we've had a new option available to us, which is luspatercept. And I just talked about those ESAs really increasing early erythropoiesis, early formation of red blood cells. And luspatercept is thought to work by basically acting on inflammatory cytokine receptors and blocking them and allowing late stage development of red blood cells. So acting a little bit differently than the erythropoiesis stimulating agents in the lifespan of a red blood cell that's developing. So this drug is a really useful option for us that was initially developed in patients that hadn't been responding to ESA-based therapy, and in particular in patients that had a particular mutation, SF3B1 or ring sideroblasts. But actually as well too, there's a more recent study that was done, and it was comparing luspatercept in the first line setting to patients either receiving luspatercept or receiving an erythropoiesis stimulating agent, and actually found that within that study, luspatercept outperformed the erythropoiesis stimulating agents in terms of the main criteria for that trial, which was a decrease in the amount of transfusions needed to maintain an adequate red blood cell count. That said, that trial was enriched for patients that sort of have some genetic markers and features that we think in general would respond better to luspatercept. So I will just say that in general, there's still a lot of debate and questions about what's the right first line choice for a lot of patients. Is it luspatercept? Is it an erythropoiesis stimulating agent? And a lot of times that's kind of driven by what's the baseline EPO level for a patient? What are their genetic changes? Do they have genetic changes that seem like maybe they'll be more likely to respond to luspatercept? And then the other thing too is luspatercept can have some side effect of fatigue that actually can be an issue for patients that seems to be slightly independent of their anemia. And then the other thing with luspatercept is it can have issues sometimes with hypertension. It's totally treatable with our normal approaches for high blood pressure, but can be an issue for some patients. And these are some of the, I think, kind of extra issues sometimes that we can run into when we think about using luspatercept. There's a newly approved option, imetelstat. And this is a telomerase inhibitor. And telomeres are protein enzymes in our cells that actually help sort of protect the cap ends of our chromosomes. It's kind of like the aglets on shoelaces. And so basically what was developed was instead an inhibitor against that particular activity. And imetelstat was looked at in patients who are no longer responding to erythropoiesis stimulating agents. And in a large trial that was comparing imetelstat to placebo, we actually found was about a 40% response rate versus a 15% response rate for placebo. The major issues with using the drug in that trial were actually decreases in the other blood cell counts, decreases in the white blood cell count, and in the platelet count for patients. Arguably, this is more an effect in the first couple of cycles of this drug, and it's something that can be managed with dose reductions. But it is not necessarily entirely clear yet, I think, for all of us who are, say, outside of a clinical trial practice setting, how best we're going to approach this and think about this and use this and manage those cytopenias. My understanding from one of our colleagues is that there is no one yet in the state of Pennsylvania that has this drug on formulary. So it's a very recent and new change, and we're excited about it. And its role right now is probably a good option for patients that haven't responded well to an ESA or luspatercept. That's a little bit of our approach for anemia. For patients that have thrombocytopenia, low platelet count, there is an option that we use in other settings for patients with low platelet counts. We use what are called thrombopoietin agonists, TPO agonists. And thrombopoietin sounds a lot like erythropoietin, but instead of the erythro or the red blood cell, this is actually trying to increase the platelet count. There's been a long story that I'm not going to get into today about trying to use these agents in myelodysplastic syndrome. There at first was some attempts to combine the TPO agonists with hypomethylating agents in high-risk MDS, and those trials were negative and didn't show much of a benefit. And in particular, there was a lot of concern that early blast cells in the bone marrow also have a receptor for TPO. And so if you're giving TPO, maybe you increase the risk of someone developing AML. What's been looked at and studied over time is that there's not really a difference that we've seen so far in progression rates to AML, despite some of those blast cells having the TPO. And that in general, too, this may be a good option for patients with low-risk MDS that don't have a lot of blasts in their bone marrow, who are having problems with a low platelet count. It's totally worth us thinking about and trying this agent for people. Dr. Prats is going to talk about hypomethylating agents, which are critical in how we manage high-risk MDS. It is an option in low-risk MDS for our patients. And in particular, I just mentioned it to say that over time, what we've really learned, and a lot of folks at Moffitt and MD Anderson and University of Colorado really helped sort of show that lower dose of the hypomethylating agents is typically what we use in low-risk MDS. And so instead of giving, say, 5 days of therapy, we can give 3 days of therapy. So I want to just pause a little bit about how I was just talking about high-risk MDS versus low-risk MDS. And when patients are diagnosed with low-risk MDS, sometimes we think to ourselves, well, eventually that may progress to high-risk MDS. So then the question becomes why, and who does that happen to, right? And in general, we're still an area that we're really learning about, right, as a group and as a community. But in general, an increasing number of mutations and certain mutations, like, say, TP53 mutations, we feel people are more likely to evolve over time from low risk to high risk MDS. People with germline mutations, a family predisposition to causing their MDS, may also be at higher risk of evolving over time. And then for everyone too, new clones or new mutations can emerge over time, and that we see this especially to be the case in patients with refractory disease. I was talking a little bit before coming up here, and I think maybe it's a little bit helpful to mention, I was worried that there were far too many slides, but that there was a study done by Moffitt in Florida, and they looked at 1,900 patients diagnosed with low-risk MDS. And they followed those patients for about 8 years. And what they found is that about 2/3 of those patients, when they started with low risk or very low risk MDS, stayed in that low risk MDS category. But that also means that a third of patients actually progressed into high-risk MDS, and about half of those patients also are progressing into acute myeloid leukemia. So the point on that is that this is not really a fire and forget sort of clinical management setting. This is a staying on top of your follow-up and with your team about monitoring and thinking about, are things changing for me? I'm not going to talk about stem cell transplant, only to say that it is not historically what we consider for patients with low-risk MDS. There are certain circumstances, if patients have moved through multiple lines of treatment, or if a patient has some sort of genetic change that we think makes them particularly high risk, they're at the age of 60, over the age of 60, and we think that there's a chance that this could help them. It's something we think about. There was a whole separate talk about iron overload on Friday, so I'm not going to mention it here, other than to say that for some people who get a lot of red blood cell transfusions, we think about how do we handle the buildup of iron in the body. And then just to sort of close out here is thinking about how will we manage low-risk MDS. So I just talked a little bit about all of these different treatment options that we have today. And when we're thinking about the future, we're all going to get more comfortable with the imetelstat and how it fits into our treatment paradigms and how we use it. The other thing is that a lot of these drugs now are being studied in combination. And so, for example, again, the group at Moffitt is really looking at lenalidomide plus luspatercept. How do we combine these agents together? And we don't yet really have the answer to any of those questions. Those trials are ongoing. They'll be interesting, but it's not really something that I think is ready for us to talk about, today in a setting like this. And then the other thing that's really emerging is, can we target particular genetic changes better? And then a lot of drug activity and development is happening in high-risk MDS. And then the question will become, are there some opportunities to bring that into our low-risk MDS patient population as well, too? So some recent really big clinical trials, just to kind of mention them because they're out there. Imetelstat, again, we just talked about it. It's just recently approved in June. We're going to learn a lot more about how it fits in, especially for our patients that have disease refractory to ESAs. There was what many thought to be a promising drug, roxadustat, that recently just failed to meet its endpoint in a big phase 3 trial. I think the only thing that I'll mention about this is that there's a relatively high response rate in the placebo group in this trial. And my point on that is that there's a lot of patients that with the right management and best supportive care team can actually have improvements in their hemoglobin and their counts. And to some extent, that might be a little bit as to what was happening here, because it's a little bit of a higher placebo response rate than all of us would have expected. And the glass half full version of that is maybe that's really great clinical care that was happening in that trial, and you all should get really great clinical care. I don't know. There's a chance maybe someone will be able to do something with that drug. It seemed active in its earlier trials. And then just a quick word about vitamin C, because as folks go deeper into things, they may come across this as well too. There's a really interesting trial presented at what's called the EHA meeting this year, in looking at low-risk myelodysplastic syndrome and patients with cytopenias of uncertain significance. And vitamin C actually, in those patients that received it, those patients had a longer overall survival than patients that just were observed during that period. And the thing about it, just to mention, is that there was no change in the baseline genetics of these patients. The variant allele frequencies, the mutations in their bone marrow didn't change at all over the course of this trial. And so it just becomes a little bit hard to believe that you're having a really big impact on patients' overall survival without any change in the genetics of the disease that we are monitoring. But that's why we do clinical trials. Stay tuned. But I also just say also too, this is the sort of thing one might find out on the internet, especially these days. And I would just say it's a discussion to have with your doctor and maybe just to have a little bit of a word of caution with that. Vitamin C has taken down Linus Pauling and take down many of us probably. So key points for low-risk MDS that I want to leave you all with for today. MDS is a cancer that requires close monitoring, but for many people, it can be a chronic disease. For some people, it can be a disease that requires a lot of treatments and intervention. We're learning more and more every single year about what is actually driving our disease, how we talk about risk, what we know. The key treatment goals for low-risk MDS are actually improving usually the anemia that is associated with the disease and someone's quality of life. Bone marrow transplant and other things that are associated with treatment for high-risk disease, they're important options, but not usually what we think about right away in low-risk MDS. And also, too, we've learned a lot in how we treat high-risk MDS and AML, and this whole thing is a spectrum. So as we learn more there, I think we'll learn more, too, in how we approach low-risk MDS. So the real goal is that people are living longer and living better, and that's what we're looking to do here, too, for everyone. So with that, open to questions. And I know there's at least one online.
Do we have any in the room?
Or actually, the one online might be just that you can put questions here. I don't know.
Okay, I do have a couple of questions from online. One being, are there any clinical trials for low-risk MDS patients and they're also asking if there are any risks or benefits associated with clinical trials for low-risk MDS?
Yeah. So I'm going to rephrase that back as saying, how do I think about is a clinical trial right for me, right? Or asking about a clinical trial is right for me. Because there are absolutely trials going on in low-risk MDS. So when thinking about a clinical trial, the real question is, what are my treatment options outside of a clinical trial? And what is the purpose of the trial that is available to me? Clinical trials are done for a whole range of reasons, and sometimes they're done for us to help find the right dose of a drug to give, and that's more of like a phase 1 trial. Sometimes they're done to assess the safety of a drug. That's a phase 2 trial. And sometimes a clinical trial is done to really establish the risk-benefit of a treatment, and that's a phase 3 trial. And so each of those trials, you could also imagine, are more likely, the later stage a trial is, to be beneficial to the individual enrolling on that trial. The key other thing about it that I would say is that, yes, there are absolutely clinical trials, and our clinical trials in low-risk MDS have led to a lot of new different treatment options as well, too. So I think it's always really important to ask what's available. And yes, there are absolutely ongoing clinical trials now in low-risk MDS. A lot of the development is more focused on phase 2 trials that are looking to combine drugs, like I was talking about earlier, at the most point now. And there's a few other drugs that I skipped over the slide, but there are a few other drugs that are phase 1, phase 2 that also are out there and people might consider enrolling in. But I think the real question then too is, what are my treatment options outside of a clinical trial is also a really important question to ask.
Yeah. Our next question says, are there any studies that show long-term treatments with HMAs to reduce the chance for moving to AML?
Yeah, so I'll actually just say that that'll be in Dr. Pratz's talk and how we think about it from a high-risk MDS perspective. From a low-risk MDS perspective, maybe I can actually just go back here as well too, and say that there are certain certain important thing with low-risk MDS and hypomethylating agents where we really actually can see for some of our patients an improvement in their blood counts as well too. In terms of thinking about overall survival, this particular trial here that I'm showing, for example, isn't comparing to placebo, There isn't necessarily a really strong evidence base for low-risk MDS in the use of hypomethylating agents to prolong survival or decrease transformation to AML, then that data is more important in the high-risk setting. We can talk about that in the next talk. Other questions?
We do have one more online. It says, once you are receiving transfusions, is BMT an option?
So oftentimes where we would think about and how we think about treatment for MDS in general, historically, a lot of people thought about kind of transfusion dependence being this bright line in how we approach treatment. We started to really accrue evidence, and your European colleagues have been showing this for a long time, that some level of starting even before someone is needing regular transfusions with the ESAs helps improve overall survival for patients. And so my point on that is just to say that, transfusion dependence historically has been a big moment where we think about things, but it is important to think about treatment before that. In regards to stem cell transplant, though, stem cell transplant really isn't necessarily what we think about or start reaching towards just because someone is transfusion dependent. No. Could it be that there's a patient who has become transfusion dependent that also has like a TP53 mutation and other factors that make us think about a transplant, or is transfusion dependent and refractory to all of those other treatment options that I was talking about previously? Then yes, but it's not something at all that just because someone needs transfusions that we think about going to right away. That is not something that we do, especially not for patients with very low risk or low risk disease. No. Other questions?
I think this will be our final question today.
Well, just to make sure, anyone in the room, I know we chatted a little bit before. Okay, sorry, go ahead.
For RS-ESA refractory patients, do you think there's more evidence to use imetelstat instead of luspatercept?
No, I would luspatercept. I don't. I think we'll figure that out in the future if there's different changes from that. But I would say that a lot of us have had more experience with luspatercept at this point as well too, and there would be, in my mind, I kind of wish that I could say, well, we have this big subgroup of patients that we know aren't going to respond too well to luspatercept or something like that. But no, I not at this time. I would have a hard time making that jump. Okay. All right.
Thank you so much, Dr. Matthews, for sharing your time and expertise with us today. For those online, this session was recorded and the slides and the session will be available on the AMDSIF website within the next 7 to 10 business days. If you're watching online, thank you so much for joining the session today. This concludes our webinar.